Welcome all to our broadcast. I'm your host, Fanny Hansen. As a reminder, the information provided during this event is for educational purposes only. It is not intended, nor is it implied to be a substitute for medical professional advice. If you have any questions regarding medical conditions or treatment plans, please consult your physician. Participating in this event does not create a doctor-patient relationship, so let's get started. Introduction for our who we have on today with us. I have Dr. Phoenix Nguyen. She's the Medical Director of Advanced Endoscopy here at St. Jude Medical Center in Fullerton, and one of our GERD patients, Michael Zalvadar. Welcome, both of you. So let's get started. And Dr. Nguyen, can you tell us about what you do in your role here at St. Jude?
So I'm the Medical Director for Advanced Endoscopy at St. Jude Medical Center in Fullerton. And we use endoscopy for therapy. And today we're talking about GERD and GERD health.
Wonderful. And Mike is one of our wonderful patients that had the luxury of having Dr. Nguyen as his doctor. Can you give us a background on why you ended up seeking treatment for GERD with us?
Yes. For probably the longest part of my life, I always had some kind of acid reflux, acid indigestion, and to a great extent was like almost every single meal I experienced heartburn, the kinds of things that people talk about all the time. And I really didn't know what to do. And early on, they didn't really have any kind of procedures to handle this. And it was very much you lived on Rolaids or Mylanta. And, many years of doing that created issues for me that ultimately, when I did have an endoscopy, I was referred to Dr. Nguyen.
Okay, wonderful. And so, Dr. Nguyen, can you give us a little information about what GERD is?
Sure. Can we open up the slides?
Yeah, that'd be wonderful.
Sure. Okay, next slide. So the reason we're interested in GERD and why we're here today is because I think GERD is associated with esophageal cancer. So we've seen over the years since 1975 a rise in incidence of esophageal cancer, and that has to do with GERD, very related to the disease. So GERD is gastroesophageal reflux disease. And if you compare it to other cancers like melanoma, lung cancer, esophageal cancer, far surpass in the incidence rate. And of course, along with that goes mortality. So you're encountering a very significant disease, and we're not aware of that. Most patients don't know that GERD can cause a very severe condition. Next slide. So GERD affects a quarter of the American population. So you're looking at 81 million people affected. And so you're not alone. A lot of patients have this similar condition if it is GERD that you have. And a quarter of those take some kind of anti-acid medication on a regular basis and monthly basis. And very few patients visit a doctor to have an evaluation. Patients take anti-acid medications. They take this medication called proton pump inhibitor, or PPI, and they use it for years, and they're not also aware of the safety concerns associated with the medication. Next slide. So GERD is defined as an abnormal, frequent reflux of stomach contents back up into the esophagus. And typical GERD symptoms include the heartburn, chest pain. You can regurgitate the food from your stomach. You can have gas, bloating. Some patients have problems sleeping. Atypical GERD symptoms, patient can describe a cough, hoarseness, sore throat. Dental problems can be associated with GERD. Also patients with asthma and lung conditions as well. So next slide. What causes GERD? It's pretty much now we understand it to be an anatomical problem. And normally when you eat, you swallow and the food goes down into the esophagus. And at the bottom of the esophagus, there's a muscle, and that's called the lower esophageal sphincter. That sphincter will open up, your food goes through, it goes into your stomach. But in patients with GERD, intermittently that muscle will open and then food goes back up, and that's the intermittent relaxation of that sphincter muscle. What happens in addition to that is you can have a hiatal hernia. Okay, so a hiatal hernia is part of the stomach back up into the chest above the level of the diaphragm. So there's a length to the hernia, and there's also a width to the hernia. And we think that's actually the second sphincter or the second mechanism that goes behind GERD in addition to that lower esophageal sphincter. The angle that the esophagus forms with the stomach is another mechanism. There are a lot of ligaments that are in this area to kind of hold the structure in place. So the more of these mechanisms that are broken, the more severe the condition will be. Next slide. So GERD is actually spectrum disease. You can have milder symptoms or you can have more severe conditions, and the more severe would be precancer or cancer of the esophagus. And on the spectrum, the more severe the condition, we intervene more. And the milder the conditions, we can do some lifestyle changes. The intermediate category, you can try the anti-acid medications with some of the listed side effects that I will cover. And also the anti-acid medication decreases the acid, but you still regurgitate non-acidic material. This TIF procedure is what I'm going to cover today. Is an endoscopic technique to fix the mechanical problem to decrease GERD. And this bridges the pharmaceuticals or the medication and more invasive surgery. Next slide. So we've seen recently this medication, an anti-acid medication, Zantac, being pulled off the shelf. This was heavy in the media a few months ago, and the FDA ordered it to be removed because of risk of cancer from a carcinogen that's in the drug. Next slide. Then you have the list of many reported side effects and associated complications related to taking long-term proton pump inhibitor or that PPI medication. Some of these may be association, but the believable ones, I believe, is osteoporosis and kidney disease. So patients come in, they have osteoporosis and they also have GERD, and they often ask, well, what can we do to treat the condition so that they can get off the PPI? And often they're on their medication for a long time. So many listed side effects related to anti-acid medication, PPI use. Next slide. So before we talk about therapy, we talk about what are the diagnostic tests that we have to do or look at prior to treatment. And typically an endoscopy to look at the inside lining of the esophagus, make sure there are no complications like inflammation called esophagitis or precancer called Barrett's esophagus. We do a manometry study to look at the function of the esophagus. We want to make sure that the esophagus can pump the food through before we fix the mechanical problem at the bottom of the esophagus. A pH test looks at acid reflux. So we have attached typically a little probe inside the esophagus, and we measure acid over time, and we document that the patient has GERD prior to considering therapy. Next slide. So those are the diagnostic tests. So the TIF procedure is what we're talking about today, is a non-invasive technique, incisionless. So that's TIF, or it's transoral through the mouth, incisionless, no incisions, no surgery. And fundoplication is creating that valve to prevent acid reflux. We have very good study looking at long-term follow-up. We have up to 10-year follow-up. Many thousands of procedures done to date throughout the U.S. And this, as I said before, represents the treatment gap between medical refractory disease and the more invasive surgical approach to correct the problem. This procedure is typically paid for by public and private payers and endorsed by many surgical and GI societies. Next slide.
So, Dr. Nguyen, we do have a question from the audience, and you did touch on it, but if you can just talk a little more about the life expectancy for this GERD treatment. I think maybe we could talk about, like, I know you said the 5-year and the 10-year, what's the expectation after a TIF that people can see success?
Sure. As with everything, we can't promise long-term success, but we do have the 10-year data. At 5 years, when we look back endoscopically, we actually see that the valve stays intact after we've created it. It's hard to actually say that it's going to be the same for every patient, because actually what happened is life happened, right? You eat and your stomach distends and the stomach pushes up. And so after we fix the mechanical problem, we always tell the patient, well, if you go back and you do what you did before, then the disease will represent itself earlier than you would like. So it really depends on the patient and what they do. I think everything in moderation would be wise. A lot of the foods that patients have to avoid prior to therapy, they're now able to eat. But of course, if you eat 10 tomatoes versus 1 tomato, the disease will recur earlier, I believe. So we do have long-term data supporting that it does last. So I will have a couple slides to answer that question, but briefly, this is what we do. It's a device. We place it inside the esophagus, and we pull the esophageal mucosa down, and plications are placed and sutures are placed. And what we create is a 3-centimeter valve and 270-degree wrap. And so the nice thing about this is that it acts as a flap valve so that you don't reflux, but it's not too tight, and it's not 360 degrees that you don't have problems swallowing after, and you don't have any problem burping. So that's what it looks like on the right. It's a schematic. Next slide. So these are some of the results. The initial studies look at randomized controlled studies. They're very good studies. And as I said, we have up to 10-year data. I'm going to skip to the next slide in the interest of time. So we look at quality of life improvement. So these are patient symptoms. How do you feel? And comparing baseline prior to therapy, it lasts. So once their symptom improve, it lasts 1 year, 3 years, and up to 5 years. And that's our current data. Next slide. That's how the patient feels. We also have objective outcome measures looking at how many of the patients go off their medication, right? And how many patients improve the esophagitis. And overall, looking at the many studies, the results are very good. Next slide. Here I have a slide looking at the effectiveness of the procedure combined with a hiatal hernia repair. So TIF can be done if it's a small hernia and not so wide, okay, endoscopically. If the patient actually has a longer hernia or a wider hernia defect, then we usually repair the hernia, bring the stomach down, bring the diaphragm together, and then create the valve. And then this is the slide that shows that it works for long term. I think this is my last slide. Next. So now here. Go ahead.
Thank you, Dr. Nguyen, for that wonderful explanation. I really am curious to hear from you, Mike, how you went from what Dr. Nguyen talked about, common people are on PPIs, how you went from that next step from deciding, okay, medication isn't working, how you got to the TIF procedure, and if you considered alternatives besides TIF.
Yes, one of the conditions I had was a Barrett's esophagus, as Dr. Nguyen had described, which was a serious condition with a kind of precancerous kind of concern. And we did several endoscopies to determine, again, where the problem was, what it looked like. And I'll tell you, it was pretty serious. I mean, I remember many times walking away with my wife and the two of us just crying about, like, okay, this doesn't look good. What are we going to do? And for a long time, there really wasn't any kind of procedures. And then with Dr. Nguyen, we started to talk about the TIF procedure. And then we had to stop for a bit because I had some other medical condition I had to take care of with regard to my heart. And so I was kind of out of pocket for about 16 months. And then we went right after I was able to see Dr. Nguyen again. We were like, okay, let's see what we can do and let's get this TIF procedure done. And we went through several preparatory endoscopies just to make sure that things were going to happen the way they needed to. But I will say that there were other alternatives that were scarier, and that an esophagectomy, removing the entire esophagus, and then implanting magnetic things into your stomach. It was just nothing was good. And I after the heart surgery, I was like, I'm not having anything, no more big stuff. And so it took a little bit, but in having good conversation, we got to the place where TIF was the solution. And it was still scary. I mean, I'll tell you, it really was. It was really scary. And I'll tell you, looking back now, it was nothing. It was really, I was shocked because after you do 2 or 3 endoscopies, an endoscopy you don't even notice anymore. And it was done endoscopically. They went ahead and they did the procedure. And I'll tell you, I was thrilled. The recovery was really easy. Now, you didn't really ask me about that. And if I could say, it was 7 weeks of liquid kind of diet and slowly introducing food again. And it really worked. And I'll tell you, I was probably bad with it in that I discovered ice cream would work. So I had a lot of ice cream along the way. Dr. Nguyen said, you'll probably lose 20 pounds. I didn't. However, I'll say that as I introduced food again, I did wind up emulsifying some of my food and wind up drinking more things than I expected. But afterwards, it has just been just heaven. And then being able to, I came off my PPI medication slowly. And I noticed that I was coming off of it, and I didn't really understand what that was. So I slowed that down a little bit. However, I was just really pleased because it's almost like I'm celebrating my stomach, and not to go overboard and have all the foods I used to love and crave that I couldn't have, but I can have everything. And it's really just been it's a peaceful kind of situation now. And we did have further testing after 6 months after the procedure, and I'll let Dr. Nguyen tell you what the results were.
Yeah, it was great.
Fantastic.
So a little bit more on the. I'm sorry, Fanny. I just wanted to share a little bit more than what he's sharing. Is that prior to the therapy, you actually had Barrett's esophagus with high-grade dysplasia, which is the next step to cancer. So it was very scary. And we had done ablation. We had done radiofrequency ablation. We've cut out parts of the tissue on the inside lining. We burned it. We can't get rid of it. We couldn't get rid of the dysplasia, which was very close to cancer. So we sent you to have this part removed. And then you said no. And we talked about links because we want to stop the acid completely from coming out because we know that that's the cause. And now, fast forward many months later, your esophagus, you don't have Barrett's esophagus. You don't have dysplasia. You don't have cancer. And you don't even have Barrett's. So I know. It's amazing. It's a great, beautiful story.
And I don't even have acid reflux.
That's wonderful.
It's like I got like a baby's esophagus. It's all brand spanking new. That's what it feels like.
I have a question for Mike brought up, Dr. Nguyen, if you could explain to everybody listening why it's important for the diet progression after this procedure, why it's, you do a liquid diet and then slowly advance the diet. What's the reason for that?
Sure. So it's an overnight stay. So we keep the patient overnight. The next day, we make sure the patient's eating, everything's good, they feel good, and we send them home. And initially, we have patients on clear liquids so that after we've worked on the area, of course, there's swelling, and it's going to be more narrowed than after the recovery period. So we keep patients on for a few days of clear liquids, a couple weeks of thick liquids, and then we advance it to soft and then back to a normal diet. And that's just for Precaution, we don't want food to get stuck while you're healing. We do limit the activity initially because, of course, you're not eating. We don't want to be running a marathon. We also limit the amount of weight that you lift because we don't want pressure on this area to tear the area that we worked on. Yeah.
Okay. And so since the procedure, Mike, have you had any regrets or any suggestions for people out there that may want to have this procedure?
Well, the real concerns of a high dysplasia and the Barrett's is really cancer, and it was very scary. A lot of heartbreak and fear and like not knowing what to do, a helplessness feeling. All of that was there, and what I'll say is that if you haven't considered TIF, you really should, because it is just miraculous in that it uses the parts you have, just kind of folded around, and I'm not going to describe it because I don't know how it's all done, but creating a new sphincter for me with what's there, and to see the results. I'll tell you, we cried. I mean, I would get some tears right now about how wonderful it was because Dr. Nguyen never had good news for me. It was always bad news. Every time we did an endoscopy, it was always bad news. And after 6 months, when she went back in and she said, "There's no dysplasia. There's no Barrett's." Man, you can't pray for anything better as an outcome. So.
Yeah, that's wonderful. That is really wonderful. And now, I often wonder how people go from their primary care doctor's office who's prescribing PPIs. How do people finally get to you, Dr. Nguyen? I mean, what's your suggestion for people if they're going to their doctor and they're feeling like they're having acid reflux?
So initially, patients will, if they're still symptomatic on the PPI, or they have been on it for 20 years and they want to consider getting off it, or they're Caucasian male patient who worry about cancer development, and you can talk to your doctor. They'll do the initial evaluation. Sometimes patients actually just call and say, "What can we do for the GERD?" It looks like we have a question about the Barrett's esophagus, and is surgery contraindicated or recommended? Actually, so this is classic. For Mike, he had Barrett's, and we had treated the Barrett's, and it was still there, and we went on and did the fundoplication. So no, surgery is not contraindicated after you've had Barrett's esophagus therapy.
And then I wonder, the next question, Dr. Nguyen, from the audience is, I know overnight for TIF is just a one-night overnight stay, but if you do the combination case where you also repair the hernia, is it also just an overnight stay?
Yes, we keep the patients overnight, whichever technique that we use for the fundoplication. Yeah, we want to make sure the patient's swallowing okay the next day. Make sure they move around, make sure they feel good. And they usually go home on a little bit of pain medication, but usually patients don't need it. Anti-nausea medication, just in case they are nauseated. We don't want them to vomit through the valve. And we keep patients on the PPI for short term. I use it for healing, and then usually we taper the patient off the PPI down the line.
Okay. And another question from the audience, Dr. Nguyen, is, my husband has a hiatal hernia, no true symptoms of GERD. Is bloating or stomach distension associated with GERD or hiatal hernia?
So the first part of that is you can have a hiatal hernia, still have GERD, but don't feel it. So you can have silent reflux. So you can aspirate, it can go in your lung, cause lung damage, or you can regurgitate and not feel it, so you don't have the burn, and you can have atypical symptoms. So the true symptom of GERD is hard to elicit, but you can have silent reflux. Bloating, some patients with GERD have epigastric bloating that can be associated. But again, there are typical symptoms that I talked about, and there are atypical symptoms.
And
both
if you have
can be treated with TIF. Sorry.
If you have the atypical symptoms, how do you determine if a TIF would be the correct procedure for this condition? What are the next steps?
Yeah. So with the pH study, that little capsule that we place to look at acid reflux, we can also correlate with symptoms. So during the study, we look at acid reflux in the esophagus, but the patient will also tell us they're having a cough or they're having shortness of breath, and then we can correlate it with the reflux event. Really, the true definitive diagnosis would be after therapy, and if the atypical symptoms resolve, then we say, okay, it was GERD. But short of that, everything else is a little bit much of a guess.
Okay. And then we do have one final question. Is this an alternative to a traditional hernia repair procedure?
Yeah. So the traditional way of doing the repair is called a Nissen fundoplication. So it's a surgical technique, and we wrap the stomach completely around the bottom of the esophagus. So it's a 360-degree wrap. And we've seen that there are some problems with it, that patients can have problems swallowing and kind of a bloating, and they can't burp. So we're leaning away from doing the Nissen fundoplication recently. And the two competitive techniques now is really that magnetic ring that Mike talked about, and TIF. I think the advantage of TIF is that there's no foreign body, and the magnet ring is 360. So we've seen patients have problems swallowing and problem burping as well. So that's pretty much the alternatives that are out there. Does that answer?
I think that answers the question. Just, I mean, we're almost out of time. I just want to ask either of you if you have any, thing to tell the audience, Mike from your side or Dr. Nguyen from your side, if you have any closing, suggestions for people suffering from GERD.
I just wish this was available 20 years ago, when there really wasn't any alternatives. Nobody had anything to do. They just drink Mylanta. That was it, or something like that. And I'm really so grateful for the work that Dr. Nguyen did with us, even though it was always bad news. As I said, it actually turned out to be the best news. So thank you again.
Wonderful.
Thank you. Thank you.
Thank you. And Dr. Nguyen, any closing words of wisdom for our patients out there?
Yeah, I think you don't have to suffer, and I think you're not alone, and it's treatable. And I think that look into it, read it, talk to your doctor about it, and we can take care of the problem endoscopically without surgery. Yeah.
Yeah. And that's the key, is without surgery, endoscopically, your recovery is quicker. You're not in the hospital for a long period of time with big incisions. So thank you both for your time and for explaining this to our audience. And we hope that, we answered some people's questions out there.
Thank you. Thank you
very
very
nice.
much.
Thanks.
Thank you both.